Welcome to the Accidental Health Show. I'm Dr. David Bohn, and it's my pleasure to have Dr. Carls with us today. Where do we start with the shoulder?
I tell you, Dave, it's a great subject. It's an amazing joint. One of the problems with the joint is, first of all, it's a great joint, and then it can move in a huge range of motion. So you can do a lot of different things like throwing type activities with it, but at the expense of stability.
Unlike the hip, where we have a little of both.
That's right. And the shoulder really has a lot of structures to keep it stable, that need to be intact, need to be working right to keep it stable. One structure is the rotator cuff. It's a series of muscles.
I was just going to say, what exactly is that? So the next time a patient's in my office and they say, I tore my rotator cuff, people don't understand what exactly is the rotator cuff.
It's a series of 4 muscles that go into basically a common tendon, and it hooks in basically inside your shoulder, right on top of the ball of the shoulder. It rides right over the ball and cup of the shoulder. The rotator cuff is important because it helps start the motion to bring your shoulder up. At the same time, whatever motion you do, it keeps the muscle tendon unit helps keep the ball in the socket. It helps it keep it in the best position possible to move.
When you look at the shoulder too, what people don't realize is how shallow that cup actually is.
That's right.
You know, it's not actually setting in something stable like when you think about the hip joint. There's that ball that eventually wears out. So it's kind of gliding there, and like you said, that stability issue can affect any age, right?
Absolutely. And you know, just like you said, it's a real shallow cup. It's a fairly big ball. It's like a golf ball in a tee. And the big ball and a small tee, and so the little tee needs to be the cup that God gave you, that He gave you, needs to have a little extra tissue around it to make it stable. And there's something called the labrum, which is kind of a cartilage tissue around the cup. And then there's a rotator cuff that kind of helps keep things in place. And then there's a balloon type capsule that surrounds the shoulder that also helps keep things in place. So it's a really complicated joint.
So we got, as a matter of fact, today alone, I had a lady tell me she had been to a healthcare practitioner and told her she had bursitis. No imaging, no testing, nothing. Just, well, take these pills. If this dose pack doesn't help you, come back and I'll inject your shoulder, and that's going to take care of it.
Right.
And I said, you know, that's probably not a good place to just start injecting without any imaging. So if we have a shoulder pain, how should we approach that? Our shoulder's hurting. It's been hurting a while. Let's say I have pain. It's been there for a couple weeks. It's not getting any better. When's the point I should think about calling someone?
Sure. A lot of times, you know, say you're out in the garden working, a nice spring day, or you started doing a workout that you really haven't done before. You have buy a new machine, and you get to work on it. You haven't done it in a while. Soreness is part of a lot of activity. And I think most people know when they're just sore from doing an activity they haven't done for a while versus you really hurt it. But there are some times, say you're working out and you get a little pain in the shoulder, and the pain doesn't go away, and it's not decreasing. You wake up in the morning, it's incredibly stiff, or you have pain at night, let's say, which is a classic rotator cuff type symptom, and the pain just isn't going away. You try to work it out, you try to stretch, and maybe 1 week is going into 2 weeks, Tylenol's not working, Motrin's not working, whatever you do initially, you try to work it out under warm water in the shower, it still hurts. If it continues to hurt or is getting worse, I would say over a couple of week period, a couple of weeks, and things aren't getting better, you might want to see your primary care doctor initially. It's obvious if you've injured your shoulder, if you've fallen on it and you feel a crack and you can't move it. Then you're talking about maybe a fracture or something else going on. But if it's a pain that feels like a pulling type pain, you did some activity that might have incited the event coming on, and then it continues to hurt. At that point, you probably should see somebody.
Now, is there a danger if, let's say, that 2 to 3 week pain goes away, and then the next time you're, scrubbing the counter down or something, and then it starts to hurt and it lasts a little longer? Is there a point that you're doing more damage every time you flare it up, and you're thinking, well, it's going to go away, and maybe it does 3 or 4 weeks down the road, and you just don't seek care? Are we risking long-term injury or permanent injury because we're ignoring these recurrent flare-ups of our shoulder hurting?
Yeah, that's a good question. If you continue if it keeps hurting, you're not doing anything about it, it hurts worse and worse, and you say use it less and less, which a lot of people do, it can become a very stiff shoulder.
They start doing more with the right-handed, and I'm doing more with my left hand because they're ignoring and not doing anything. What's the danger to that? What are you going to end up having to do because they've ignored?
If you can get what's called a frozen shoulder. It does happen in some disease process more than others. Diabetics, thyroid patients sometimes are higher risk for getting a frozen shoulder. But bottom line is, if you don't use it, it's inflamed, it hurts, and then because of the vicious cycle, you don't use it, you don't move it, it gets stiffer. Every time you move it, there's a little more pain because now it's getting stiffer. It becomes a frozen shoulder and you're not using it. That's a situation where you really need to see someone soon, because once a shoulder gets stiff, you can work it out with therapy. You can do different techniques, including injection, if that's part of the therapy that your doctor discusses with you. Definitely is a good tool because it decreases inflammation.
Help them get past the pain a little faster too if you're trying to forcibly move the shoulder back.
That's right. It decreases inflammation, and therapists can do different things, and I know you do different things to help with inflammation and get motion back. And there are many external things that you can do, which you know much better. My
problem is always, like I was saying, the person waits until it's too late. It's past what I can do, and then I'm calling you, or I'm calling the other. Hey, there's more here than what can be done.
That's right.
And I'm sure we want to talk a little bit about that next step.
Right.
Why you want to do what we do before they have to go that route. Because
that's right.
If you don't do something, they're going to be knocking on your door eventually.
Right. And definitely for most shoulder problems, I mean the vast majority, unless it's a trauma, initial trauma, conservative treatment is always tried first. And we're talking anything from a dislocation, a young person in a sport, generally would try conservative treatment first, to a rotator cuff tear, we try conservative, meaning non-surgical treatment first, always therapy, always trying to get the pain and inflammation under control, and so forth. Younger patients with dislocations, and I won't get into that as much tonight because we were kind of going to talk about rotator cuff and impingement issues. It's a whole nother subject. That's a different problem. You can rip structures by popping your shoulder out, which definitely might need surgical correction later. But still in those patients, unless they've broken a piece of their bone off, we almost always try non-surgical treatment first. There is the separate collection, the separate group of elite athletes, NFL, baseball players, pitchers, and you hear about them getting surgery right away. In the community, we're a little more conservative. There are some patients, and especially if they've dislocated several times, we'll start to see that it's really becoming a pattern, and that therapy alone and shoulder girdle strengthening alone isn't enough. And then that usually warrants surgery. But first time scenario, most patients, absolutely, you're right. It's conservative treatment, trying to decrease inflammation and pain. And one thing therapists always tell me, I'm sure you see it too all the time, is that if you try aggressive therapy without getting pain under control, it actually can be counterproductive. And so you really have to try to get down that acute inflammation, that acute pain, and then you start pushing a little more of physical therapy, but it is a fine balance.
Well, ideally, that's how, when I have an acute shoulder, I want to work with the primary care physician or the orthopedist. I want them on something.
Right.
Because as you're trying to work it or calm it down, every time they move it, they're making it worse. So it's good to have something to help get that inflammation down, keep the pain down so they can rest and so they can do some gentle therapy and get started on the path to healing.
Right. And that is really a balance that sometimes it's tough to get initially between all of us working together, but you're right. I mean, all of us professionals working together, it really takes that. The first step should be with a patient, should be basically they're saying to themselves, something's not right. My shoulder now has been hurting for a while, it's not getting better, feels like it's getting stiff, I'm not using it like I should be using it. It might be swollen, but shoulders don't swell that often. They really don't, unless it's a acute traumatic injury or something. But if it kind of lingers, then you really ought to think about seeing first person to see is your primary care doctor, because they can do initial treatment and then refer you to the right people.
Well, just from when you say swelling, in case somebody's listening, like a bursitis or an inflammation, something deep, but you don't see the shoulder blow up.
Yes.
Is what you're talking about, right?
That's true, right.
Yeah, 'cause
Bursitis,
you can have a lot of swelling going on inside the shoulder.
That's right.
You just
Yeah.
don't see the outside suddenly turn Popeye against the other side.
Right, right.
Yeah.
I mean, other joints, you see that more.
Yeah.
You see that in the knee more. You see it in the elbow. The shoulder has a lot of meat around it, and generally, yeah, bursitis is an inside process. It's underneath this hard bone here.
Yeah, so you don't really get to see it on the outside.
Yeah, right.
So you were talking about impingement. Are you ready to move to that topic?
Absolutely.
Interesting term. That's another misused one. I have
You
a shoulder.
see it all the time.
I have shoulder
Yeah.
impingement, and they have nothing of the sort. So
Right.
what exactly is shoulder impingement?
Impingement, when you talk about bursitis and impingement, we use them almost interchangeably. Impingement, we think about impingement, when we think about when you bring your shoulder up, and this ball, let me get my model here. When you bring the shoulder up like this, it's called abduction. And when you bring the shoulder up, you can see how it impinges the tendon in the rotator cuff up against this hard bone.
Which is,
and
so
series of
for the person
ligaments.
that's looking and doesn't, this is the end of their collarbone coming over into the shoulder, right? So we're
That's
just
right.
kind of orienting it for people that may not know what direction you're pulling
That's
that arm.
right. That's right. It's hard on TV. I've got to hold this position. So this right here is your collarbone, and the collarbone comes into this. It's called the acromion, which is this bone on top of the shoulder. It's the hard bone you feel on the top. Around the back, you have this. This is the scapula, and you feel the spine. That's that hard spine you feel back
What
there.
they would call their wing bone or something.
That's right,
Yeah.
their wing bone. And so this is the back, and then this is the front with the collarbone here. When you raise your arm up, you impinge this area up against here. The bursa is up in this area. The bursa is up under this area. All a bursa is a area in the body, and there's multiple, it's like a little pad, and it can collect fluid when it's irritated. Bursitis of the elbow is common. In front of the knee is very common. And bursitis in the shoulder area just means you get inflammation up under that area, which is the area for impingement. So impinging, it's impinging. It's like a door stop. You swing a door open and something's stuck right where the door is supposed to continue going, and it can't, and it just gets stopped.
And anytime the body impinges, it's painful.
It's painful, right?
Just might as well just put equals pain.
Equals pain, just like hip impingement or
That's
anything
right.
else. That's right. That's right.
So what do you do for that case? What happens with the shoulder impingement?
It's usually modifying your activity. In other words, if it's if the patient is a thrower, they might have to lay off their fastball for a while. They might have to. Good coaches will check out their throwing mechanics and say, you might be doing this wrong, you might be doing that right. Nolan Ryan pitched a lot of years because he had excellent mechanics. Pitchers, throwers always need to be aware of this, and a good coach will watch this. If they start getting impingement, it's from constant motion, doing the same thing over and over again, and their shoulder starts getting irritated, and they can get a bursitis. Different factory workers we see a lot in this area. New Page, or a lot of different factories around here require patients to really do a lot of physical work in a normal work day. I mean,
The
8 to
poultry
10 hours.
processing plants are
Right.
amazing how much work they do per minute, how many birds they touch per minute doing the same motion.
That's amazing.
It
I'd
is
like to go to one of the factories sometime and see exactly.
I've been there. It's
Wow.
just shocking. You say, oh, so that's why you hurt.
See, that's why it hurt, and it's a constant overuse kind of injury, and especially overhead lifting type workers. Say I've had a few drywall type workers who all they do is they put in drywall, and they're like this all the time. And mechanics, they're working like this all the time, and they're always working overhead. They're picking up huge objects. They're working with big tools, and the shoulder will get irritated if you use it too much, and that's what happens. That's how it starts, we think. And then once the irritation gets started in the bursa area, it can start to affect the underlying rotator cuff tendon area, which is right here. So you can see if you keep hitting that constantly, this can start irritating the rotator cuff area, which can help lead to a tear. And that it is all very related. Impingement and rotator cuff problems are interrelated. Also, all the structures inside the shoulder have to work just right. If you have looseness, or we call it laxity, in the shoulder, and the ball moves around more than it's supposed to, and that can be from fatigue, or that can just be from stretching out of tissue or trauma. Throwers, they get or wrestlers, taking care of a lot of wrestlers, they get very stretched out in this whole capsularity inside the shoulder, underneath the rotator cuff. From having kind of this instability, this moves around more than it should, leading to problems with the tendon. And the tendon, as it gets irritated, the bursa gets more irritated, it becomes a vicious cycle. And that's
it's hard to get it calmed down then again.
Right.
When we're talking about tears, you had mentioned that the tendon can become torn. I've had people come in and say, well, I had an x-ray and that it was normal. So
right.
How are we going to image that? How are we going to know the person that's out, how are they going to know they have a tear?
Right.
And the reason I'm saying that is people will go somewhere and they have a shoulder problem and they're told, "Oh, take this," and maybe it will calm it down. But if they have a tear and they not stressing that particular tendon or that motion, they're just going to tear it more the next time they do that particular. So what I'm getting at is, if it's hurting them, they should find out exactly what they did to the area before they just, maybe it will go away.
Right, and the shoulder is all about, the shoulder, first of all, is backing up a little bit, is difficult. There aren't that many great physical exam tests to check for different specific structures in the shoulder. We have a few good ways to test it, but primarily it's all about history. With a shoulder, you really have to listen to the patient, because they will tell you the story. 95% at least of diagnosis of the shoulder comes from history. That's what one of my professors used to say. Basically, 5% is a combination of physical exam and MRI imaging studies, such as we're going to start talking about here. If a patient comes in and they have the classic story, rotator cuff, it starts hurting worse at night, they're weak picking things up, they're of the right age group. We generally think over 40, 50, 60, you really start thinking about it more, even though we see it in younger patients, but primarily. You're probably thinking, and they have impingement signs.
The ages were starting to wear out.
My shoulder's hurting as we speak. Just picking up the bottle hurts.
Bad sign.
That's a bad sign.
We can set you up next week.
That's your first sign. Okay. I'll come see you next week. But basically, history and age and activity and the background of the patient's extremely important. But once you think, say a rotator cuff, you think that patient I talked about, say a 70-year-old patient, they're working in the garden, their shoulder really started hurting, and now it's weak, they can't lift it up well, they have pain at night, you think rotator cuff. So as far as diagnosis, pretty much that's a diagnosis, and you can then, I'd send them to therapy to get stronger, to work on their motion. If they're really inflamed and they can't move, I will consider a cortisone injection fairly quickly just to calm things down. If it's not as acute, then certain medications and external measures work very well, but definitely cortisone injections can help if it's very inflamed, just to kind of kickstart things to calm things down. MRI, though, is very good. It's the best test we have to look for the size of a rotator cuff tear, especially if we're contemplating surgery and we want to know what we're dealing with. Is this a massive tear? We call it, where basically all of these tendons are involved. And then, is there retraction? In other words, if it tears, say it tore 10 years ago. If you see the patient 10 years after they've had a terrible tear, this whole tendon can retract. It can, basically, these muscles will pull the tendon back off the ball of the shoulder. At that point, that becomes a very difficult surgical situation. It's very hard to do, and the success rates are a lot less.
Does the muscle then atrophy after being torn away, where it gets smaller?
Atrophies and scars. It's basically,
so it doesn't work anymore.
If it hasn't seen any action in 10 years, it's weak, it's scarred, it's immobile. And you try to pull back that tissue, and sometimes it's incredibly immobile. It's like cement. It's stuck and scarred in there. And so telling those patients they'll have a very successful rotator cuff repair is not realistic.
It's too late.
It's too late. There are, some big centers, like the Mayo and places like that in the U.S. that work on different ways of reconstructing using, say, your pectoralis to swing over to use as your rotator cuff. But if we're talking about your basic repair, that we do in a community setting,
That's why I was saying earlier on, don't wait to find out that you had that kind of tear. So 10 years later, your shoulder is hurting you, and then you come in and you get an MRI, and I have to say, here's where you are.
Here's where you are.
This is
and
bad.
We can't fix it. That's right. The old, and things are changing a little bit. People are getting more aggressive about surgeons are getting more aggressive about fixing rotator cuff tears now. And still the major tenet of a rotator cuff tear is we fix it because you continue to have pain. It's an operation done for pain. But if it's a large tear and you're a very active individual, say you're 75 years old and you love playing tennis, you love playing racquetball, you love playing golf, you're gonna want a little more function than, say, your couch potato 70-year-old.
I actually think I see that in my practice. I think people are moving more over the 20 years I've been doing this, more from, pain's still a big motivator. I want to get out of pain.
Sure.
But more and more people want to function better longer.
Absolutely.
They're looking at, well, if I'm going to live to 80 or 85, I want to be using my body at 80, 85.
You want it to work.
Right.
You're not going to just have this broken down jalopy that you're kind of hauling along with you. You want it to work.
Exactly.
And we talk about the different age groups. Hey, there are 80-year-old patients that can be much more active than, say, a 40-year-old patient. And so you have to look at every patient depending on your activity level. And I would say, in general, as a community, we're getting much more aggressive about fixing rotator cuff tears a little earlier than I think we used to.
Now, has arthroscopy allowed you to be a little more aggressive?
Yes, it definitely
earlier
has.
on and less invasive?
It's less invasive. It's less painful.
You don't commonly see the big scars up over the
big
shoulder
scars.
anymore.
There's no doubt the open surgeries are still the gold standard for fixing rotator cuffs today, but that is changing. Rotator cuffs now are becoming done more and more frequently just through a scope. And primarily the ones successful there are with the small rotator cuff tears, which you can easily access through the scope and it can work. Some of the well-known shoulder surgeons that are doing a lot of arthroscopy though now are really pushing the limit and are really starting to do some of the very, very large tears through a scope.
Really? I didn't know.
And most of us right now are learning those skills to try to be able to take care of bigger rotator cuffs.
It's a lot to do through a little hole.
It's a lot. It's amazing what you can do through a scope, and all of us are training in that now, trying to get more proficient at it. In general, the bottom line is to fix the tear, and now by fixing it open, it's still a great operation, and it still is the gold standard because you can see everything. You can put it together well. We have all different types of tools to actually put it back in place. But yes, arthroscopy is really on the verge of becoming bigger and bigger all the time.
Are you seeing more of that in your practice now? Is arthroscopy becoming more of what you're doing, or for the shoulder? More of that, less of?
I'm transitioning right now to we call it the mini open approach, where it really has to do with the way you get through the tissue to get to the rotator cuff, and that's what all of us are doing in this town, the mini open approach. But I'm moving towards doing these arthroscopically as much as I can, and it will take some time to kind of transition all the way there. The key thing is you can have results right now. The gold standard results are still across the nation best generally open with the mini open approach, but that's quickly changing. Now about half the community in orthopedics now that does shoulder surgery, about half the doctors are really starting to switch over to arthroscopic repair, and it does have great promise. The main advantage of arthroscopic repair is postoperative pain, and they seem to do better with rehab faster because they have less postoperative pain. It looks like a few months down the line they're all about the same, but initially it's a more pain-free postoperative period is what most docs that are doing it report. I do most of my arthroscopic repairs inside the shoulder with the labrum and with the cartilage. That's what I primarily do now, and I'm transitioning to doing arthroscopic rotators too. So
we've been talking about how you go about the surgery and what happens with the surgery and what all the indications. But let's talk now after surgery. After somebody's, I'll sometimes get the patient after surgery. Maybe they'll go to a therapist, whatever. But after they've had surgery, what do you like to see done on the rehab end? What should they expect to see?
Right, right. And this is important because everyone's getting their shoulder fixed in order to get back to work and get back to their activity.
Sometimes I'll hear people and I'll say, after your surgery, what did you do? Nothing.
Right.
Went
you
home.
might as well not do surgery.
Yeah,
if you don't have the proper, and we call it perioperative now therapy. We actually send patients to prehab as well as post-hab.
Great new words.
Yeah, post-rehab and pre-rehab. This kind of now we use because you can do therapy leading up to surgery, which definitely helps with motion. And if you have better motion in the shoulder before surgery, generally results are much better after surgery.
I'll sometimes tell people, you guys aren't like us. Sometimes it takes 2 or 3 weeks to get them in to see you if they're not dying. Because
Right.
you have other cases that obviously we understand that.
Sure.
But I'll say, well, we'll go ahead and keep treating you up until the point that you have your surgery.
Right.
And their
That's
question
right.
is, well, why would you do that? Well, there's
Right.
exactly the.
That's it. If you get stiff and you have pain and you're stiff before surgery, the worse you're going to do after surgery. It's going to take longer to work it out.
And sometimes
And-
it may actually we get a miracle and they don't need
Yeah.
surgery.
Right.
But that's rare.
Yeah, occasionally,
Usually-
especially with impingement, if it's not much of a tear, rotator cuff tear is mostly just impingement bursitis. That can be taken care of, often by just conservative non-surgical.
I'll tell a patient, if 2 weeks or so they're not getting better, I'll say, let's set you up with an orthopedist
Yeah.
and get you on the book.
Right.
If by some chance we don't need that appointment,
Right.
well, they'll fill it.
Yeah.
Don't worry about it.
Yeah.
They'll
Yeah.
find somebody for that spot. But
Yeah.
but we may have you where you need to be. But then on the other hand, you won't be waiting 3 weeks from now and then have another 3 weeks to wait to get in.
Yep, happens every now and then. A patient, the week you see him before surgery, Doc, I'm doing pretty well. What do you think? I said, if you're doing pretty well and it's a problem that really they might do well without surgery, so
Yeah,
we'll see
they're
how
not
you
an
do.
athlete or they're
Sure, we'll see how you do.
hobbyist or something like that.
It is really, shoulder surgery has to really be tailored to the person. It really does. Your question about postoperative rehabilitation, there's different phases in shoulder rehabilitation where generally we'll say take your garden variety rotator cuff patient, small, medium tear. For the first 6 weeks, they'll work mostly on motion, passive motion, where they're just basically just working on the motion of their shoulder so that their capsule doesn't get tight, so that they don't get tight around their shoulder. Generally then, 4, 6, 8 weeks after that, things are done such as called active assisted motion, where the patient will move, the therapist will help them, so they're getting some assistance while moving. And then
kind of
generally,
like a spot doing a bench press.
That's right, because the tendon is still healing to the bone. It takes about 8 weeks in general for a tendon to heal into the bone fairly well. So during that time, though, you don't want a patient to sit, doing nothing. You want the muscle to fire. You want the muscles to work. You want the motion to continue so that they don't get stiff. Then after about the 8-week mark, you can really start, and it depends how big the tear is too. It depends on the tissue of the patient. In other words, we do have to tailor it. But at a certain point, say 8, 10 weeks, active motion will start, and that's fully on their own. They'll fully start working out. They'll fully start doing, they are going to be working that rotator cuff under their own power. Then when you get to about the 12-week mark, give or take, again a few weeks, then really the resistance exercises increase. They then start to, if they're in a sport, you start to say, okay, sport-specific exercises or work-specific exercises, functional assessments before going back to work, and things like that really start to come into play. Elite athletes, really are getting back into sport-specific motions really early.
You have that much money invested in it. It's good.
Yeah, everything's accelerated. Don't listen to what they said that the latest NFL or baseball player did, because it's on a
Whole different level.
These
Right.
people have high pressures. But yeah, a patient getting back to say working at one of the industries in town, basically.
Yeah, they're not going to be able to afford a therapist 8 hours out of every day
That's right.
to work with them.
That's right.
Today it's been great having you back. I'm glad you were able to come back. You're welcome
Hey,
anytime
Dave.
to talk
Thank
about
you.
stuff here on the show. We've
Thanks.
been listening to Dr. Carl's a guest here on the show today. And as always, keep the accent on health, and we'll talk to you next time. I'm Dr. David Bohn. Have a great day.